So welcome everyone. My name is Dr. Pamela Kunz, and I am a GI medical oncologist. I am the director of the Center for Gastrointestinal Cancers at Yale Cancer Center and Smilow Cancer Hospital. This is our kickoff for our spring CME series for the Center for GI Cancers. We are starting tonight on neuroendocrine tumors, and I will be your host. On Thursday, April 21st, we will have a CME on rectal cancer hosted by Dr. Michael Cicchini. And on Thursday, May 19th, we will have a CME on gastric cancers hosted by Dr. Jill Lacey. So this evening, I have the pleasure of hosting and moderating this talk on neuroendocrine tumors. I will be giving a brief overview of NETS 101, and then we'll help moderate the Q&A. I'm joined by Dr. Mariam Aboian, an assistant professor of radiology and nuclear medicine, and she will be speaking about the role of molecular imaging and Theranostics in care of patients with NETs. And Dr. Sajid Khan, an associate professor of surgery and surgical oncology and section chief of hepatopancreatobiliary and mixed tumors, will be joining us this evening and talking about the surgical management of pancreas and small bowel NETs. So I will just go ahead and get started. So just for our audience, each of our talks will be about 20 minutes. Please feel free to put questions in the chat or Q&A throughout. We will try to respond with a typed response throughout, but we will also have time at the end for a thorough Q&A, and you can ask then. These are my disclosures. So I'm going to talk briefly about the epidemiology and nomenclature of NETs, talk about characteristics that I think really impact treatment selection for patients, and then talk about treatment for hormone and tumor control. I usually like starting with a little bit of history. So neuroendocrine tumors and the description of NETs goes back to the late 1800s. And it was really in the early 1900s that Dr. Oberndorfer, a German pathologist, coined the term carcinoid. It meant cancer-like, and he described and felt that there were 5 key characteristics, that these tumors were small and multifocal, had undifferentiated cellular formations, had well-defined borders, no metastatic potential, and were slow-growing and harmless. And though he contributed really important early knowledge about this disease, we now know that many of these characteristics are not true. And I think the term carcinoid and cancer-like, unfortunately, really slowed the field in terms of our recognition that these are in fact cancers. The term carcinoid has really fallen out of favor. And instead we are using the term neuroendocrine tumor, and then by which primary site. So we have seen an explosion of advances, both therapeutics and diagnostics, really since 2011. So in the 1980s, we had streptozocin, an IV alkylating agent, and octreotide that was initially approved for hormone control. And then since 2011, we have had therapeutic advances in the areas of biologics, of everolimus and sunitinib, somatostatin analogs, of Lanreatide, telotrestat for carcinoid syndrome, Deuterate in 2018. We'll talk about some of the other systemic agents, and then also some of the imaging agents that are listed above the timeline. I like also sort of nailing down the point that NETs are really not that rare. So they are rare by incidence. So incidence being the number of patients diagnosed per year. And this is based on a large SEER study conducted in 2017. And the incidence rate for NETs is about 7 per 100,000. This is in the yellow line on the figure compared to the blue line, which is the incidence of all malignant neoplasms, which has remained relatively stable. However, the prevalence of neuroendocrine tumors is actually the second highest prevalent GI malignancy. It exceeds stomach and pancreatic adenocarcinoma combined, and that's likely because this is a more indolent disease and patients live for many years, more commonly with the low-grade neuroendocrine tumors. NETs are epithelial neoplasms derived from neuroendocrine cells throughout the body, most commonly found in the GI tract, but also in the lungs and other sites. And most grow slowly in comparison with their adenocarcinoma counterparts. The majority are sporadic, and the minority are associated with familial syndromes such as MEN1, MEN2, von Hippel-Lindau, and neurofibromatosis. Pathognomonic for this disease is the fact that somatostatin receptors are present on the cell surface in about 80 to 90% of NETs, and this is typically with somatostatin receptor type 2. The diagnostic workup, and I will say if you take away one thing from this, it's that the cross-sectional imaging is really the mainstay of how we monitor patients with NETs. Either a multiphasic CT, and that arterial phase is critical if you're ordering a CT scan, or an MRI. Somatostatin receptor imaging is important, but is not the primary modality with which we image these patients. These are done commonly at time of diagnosis, and for patients with metastatic disease, we may do them annually or every 2 years. Somatostatin receptor imaging is now used with gallium-68 Deuterate PET or copper-64, and I'm going to actually, this will be a little bit of a teaser. I'm going to let Dr. Aboian talk more about somatostatin receptor-based imaging. The tissue diagnosis, we like to know the primary site if we can identify it. And 4 key data elements are important when you're looking at a pathology report: the WHO grade, Ki-67, mitotic index, and degree of differentiation. We'll talk about that in a moment. And then tumor markers or hormones are important for this disease, but I will say that tumor markers such as chromogranin or neuron-specific enolase or pancreastatin often fluctuate and may not actually track with what's happening radiographically. The field has swung away from using these, and I often don't use chromogranin A now because really the gold standard is the imaging. Hormones, however, such as serotonin or 24-hour urine 5-HIAA, which is a byproduct or a metabolite of serotonin, those can be useful and should be tracked over time. So I find that there are really 6 key characteristics that impact treatment: hormone status, stage and burden of disease, grade and differentiation, pace of growth, primary site, and somatostatin receptor status. I'll spend just a moment on each of these just to really set the stage in terms of how we talk about and think about treatments for NETs. So a functional neuroendocrine tumor is defined as a patient who has symptoms from a measurable hormone that's in either the urine or the blood. Carcinoid syndrome is a classic example of that. 10% of patients with small intestine NETs have carcinoid syndrome, and it's due to production of peptides and amines such as serotonin or 5-HIAA, and it can cause flushing, venous telangiectasia, as shown in this picture on the left, diarrhea, bronchospasm, valvular fibrosis, and hypotension. This is also a picture of the pulmonary and tricuspid valves that are very fibrotic. Pancreatic neuroendocrine tumors can also secrete hormones in about 40% of patients, most commonly insulin, followed by gastrin, glucagon, and vasointestinal polypeptide. And the symptoms are really defined by the hormones secreted. And non-functional NETs are defined as patients who are either asymptomatic or have symptoms that are not from hormone excess. So stage and grade. I think this is, I really try to describe this to patients because I think for patients in particular, this can be very confusing. So to this audience, however, stage is a very familiar term. What's interesting is that the AJCC staging criteria have only included NETs since 2010. This is a really nice picture here of a localized pancreatic NET, which we'll show in the video, and a metastatic pancreatic NET with high degree of liver burden, as you can see here. Grade is really what the cells look like under the microscope. Low grade is slower growing, higher grade is faster growing. We really base this on the Ki-67 and mitotic index. The 2019 Digestive Wh Classification is the most recent. Next to the red arrow is a new change that was made to this. So we have well-differentiated NET, grade 1, 2, and 3, and poorly differentiated neuroendocrine carcinoma, grade 3, and that's divided into small cell and large cell. What I didn't put on this slide is kind of the breakdown of the Ki-67 and mitotic index, but really the takeaway from this is that clinically we treat the grade 1 and 2 well-differentiated NETs very similarly. This well-differentiated grade 3 NET is a relatively new category. I think that we have to treat based on the individual patient's biology, bulk of disease. The poorly differentiated neuroendocrine carcinomas are treated very differently. That will not be the primary topic of kind of the subsequent slides on treatment. That's typical. Those patients are typically treated with platinum etoposide. So pace of growth, something I was getting to, really does inform our treatment selection. We may meet a patient with a metastatic low-grade NET who has very stable disease or slow progression, or may have more rapid progression. Some of those patients may not need treatment initially. Observation may be appropriate, whereas others may have high burden of disease or symptoms from tumor bulk, and they may need treatment. Primary site matters. I know this is a GI-focused talk, but NETs can happen in almost any organ in the small intestine. Most commonly, that is one of the most common sites. We see commonly in the ileum, but we will also see pancreatic NETs and other NETs in the GI tract. And many clinical trials and treatments are really tailored based on primary site. Therefore, FDA approvals are sometimes limited specifically to primary sites. One example of that is sunitinib for pancreatic NETs. We now know that somatostatin receptor status is critical both for diagnosis and therapy. Again, I'm going to let Dr. Aboian go into this. This is an interesting picture just to show an Octria scan, which has now really completely been replaced by gallium dotatate. This is the same patient imaged with an Octria scan and a gallium-68 dotatate PET. And you can see that the resolution is far superior with the PET-based imaging. So now we're going to launch in the next sort of the final half of my presentation on general treatment categories for NETs. I will go into some of the specifics just so that you have access to this if you choose to watch this again. So we have four main categories: somatostatin analogs, peptide receptor radionuclide therapy, biologics, and cytotoxic chemotherapy. I am going to really focus my conversation or presentation tonight on anti-tumor treatments. Just a brief comment that we know somatostatin analogs were really initially developed for hormone control and remain as the primary tool that we use for hormone control, but I'm not going to go into, just for sake of time, details on hormone control tonight. So somatostatin receptors and Theranostics, again, I'm going to just use this to talk about some of the therapies. Dr. Aboian will go into this as well. But in terms of my cartoon here, imagine you have a patient population for whom you would like to select out, do they have a receptor on the surface of their cells? We do, in fact, have that. So with the gallium-68 or copper-64 PETs, we select out those patients using that imaging, and then we in fact have a targeted therapy that goes to that target. So that's Theranostics. Dr. Aboian will focus on that. When I describe this to patients, I use the lock and key description or analogy. I think that helps them understand why we use somatostatin analogs, why we use the dotatate imaging. So think of the somatostatin receptor as the lock, the key is the peptide, and then there's a reporting unit. So for somatostatin analogs, we actually have two trials that demonstrated anti-tumor effect. The PROMID study demonstrated the effect of octreotide versus placebo, and the clarinet study demonstrated the effectiveness of Lanreatide versus placebo. Both had a primary endpoint of the PROMID study was time to progression, and of the clarinet study was progression-free survival, and they both showed a benefit over placebo. Octreotide has not formally does not have a formal FDA label for anti-tumor effect. It is primarily in hormone control, but these two agents are often used interchangeably. Lanreatide was FDA approved in 2014 as an anti-tumor agent. I like to put this up because I get asked this a lot. So how do we think about dosing for tumor control? Octreotide LAR is usually used at the 30 milligram IM monthly dose, and Lanreatide at 120 milligrams deep sub-Q. There is no need to overlap with short acting unless it's a functional tumor. I think there was data years ago that we needed to do a test dose to test for allergy. That's not generally needed in practice. And there is little data to support the routine use of above standard dose of somatostatin analogs for tumor control. The side effects include nausea, diarrhea, cholelithiasis, and hyperglycemia. I'm going to go through these quickly. I have them just kind of as placeholders, but Dr. Aboian will talk about these, but we've had incredible advances in the diagnostics for NETs as well. And there is a very handy paper, and I have this here just as a reference on the appropriate use criteria for somatostatin receptor PET imaging in neuroendocrine tumors. That's a great reference. And then the therapy is something that also Dr. Aboian will discuss, and specifically around the NETTER-1 phase 3 clinical trial. So I'll mention it just in passing that this was a study I had the opportunity to serve on as a PI when I was at Stanford. It's a randomized study that really set the stage for using Theranostics and specifically Lutetium in NETs. It was a positive study. I'll give that punchline away for Dr. Aboian. But moving on to some of the other systemic therapies I will spend a few minutes on. So everolimus is approved for pancreatic NET and non-functional GI and lung NETs. This is an mTOR inhibitor. There were sister studies, RADIANT-3 and RADIANT-4, and both of them showed a progression-free survival benefit in these patient populations, and they were both approved. So for pancreatic NET in 2011 and for GI and lung NETs in 2016. And tyrosine kinase inhibitors also have a role in neuroendocrine tumors. Sunitinib was approved on the basis of this randomized study in patients with well-differentiated advanced pancreatic NETs. So that's the one that I said we don't yet have a tyrosine kinase inhibitor approved for small bowel NETs. This was also approved on the basis of a PFS benefit. You'll notice that most neuroendocrine tumor clinical trials have progression-free survival as a primary endpoint, and that's because OS is an impractical endpoint, given that patients tend to receive many subsequent therapies after these clinical trials, and given the indolence of the disease, it would be too difficult, practically speaking, to use overall survival. So this was approved in 2011. Surufatinib is not yet FDA approved. It is under FDA review at present. This was on the basis of 2 large studies conducted in China, and then a phase 1/2 study that has been conducted in the United States in a more traditionally Western population. But this was positive in both pancreatic and extrapancreatic NETs, and is, I suspect that at some point this spring or summer, we will have a decision from the FDA. I'd like to mention a study on chemotherapy that I had the opportunity to lead for pancreatic NETs. So this was a study of temozolomide versus capecitabine and temozolomide for grade 1 or 2 metastatic pancreatic NETs. This was a study that ultimately demonstrated that Cap-Tem was superior to temozolomide alone. The median progression-free survival was about 23 months for the combination versus 14 months for temozolomide. At the time of the initial analysis, it appeared as if there was an overall survival benefit. Stay tuned, we have the final analysis submitted to ASCO for an updated analysis. I think one of the key takeaways of this is that we see a higher response rate than we've seen really for any of the other therapies. I did not go into that, but somatostatin analogs, mTOR inhibitors, tyrosine kinase inhibitors all have a 5% or less objective response rate. So for patients with pancreatic NETs who need objective tumor shrinkage, these are actually very good therapies to think about. So let's wrap this up. I think I have 2 slides left. So how do we really think about sequencing these treatments? It's very confusing. We're actually in a fortunate place now of having a number of therapies, but it gets very difficult to know what order in which we should use them. So this is adapted from the NCCN guidelines. So I would say commonly a first-line treatment is either observation or octreotide or lanreatide, but where it gets very confusing is thinking about second-line therapies. So I have a handy table to help you think about that. And I've put them in order of how I generally will think about using them. I often will consider using PRRT or Ludotate or Lutathera as it's also called, in the second-line setting. It has a modest response rate of about 18%, a long PFS, and is well tolerated. We do have to take care if patients' GFR is less than 30, but we are developing more experience with that. The chemotherapy, temozolomide and capecitabine, has the highest response rate and should be considered for patients with pancreatic NETs who need an objective response. It does have higher adverse events. For older patients, I will sometimes consider temozolomide alone. For everolimus and sunitinib, they both have very low response rates. The PFS is about a year, best for low volume disease, but I find that the adverse event profile is tough for both of these. Everolimus in particular is good for insulinoma because it can cause hyperglycemia, but it's tough and can cause pneumonitis, and the hyperglycemia can be difficult for patients with uncontrolled diabetes. So takeaways, I hope you've learned that NETs are not that rare. They are deserving of high quality, basic translational and clinical research efforts. We've had incredible advances in the last 10 years. PRT is really a game changer, and I expect the next decade of clinical trials to be looking at better patient selection, minimizing toxicities, and increasing efficacy. And multidisciplinary care and team science is really key for this disease. So I am going to stop share. I think I'm close to time. I am going to pass the baton to Dr. Aboian, and then Dr. Aboian, if you can then pass that baton when you're done to Dr. Khan, and then we will do a Q&A. Great.
Thank you, Dr. Kunz. This was fantastic. Share my screen. So I'm going to talk about the role of molecular imaging and theranostics in the care of patients with neuroendocrine neoplasms. I'm at Yale Department of Radiology, and I am in the nuclear medicine and neuroradiology sections. For disclosures, I have a research collaboration with Visage Imaging, and I do clinical trials with Blue Earth Diagnostics. We're going to start a little bit with standard imaging, CT and MRI, but we're not going to focus on this imaging modalities because they're pretty well understood in the community, and just kind of going over the basics of it. For carcinoid tumors, we can do very nice chest imaging with CT of the chest. We can do contrast and non-contrast imaging. And here's an example of a lung carcinoid lesion. For pancreatic neuroendocrine tumors, we can do CT imaging, contrast enhanced CT imaging. We can also do MRI. And here you see actually a patient with pancreatic tail neuroendocrine neoplasm that is heterogeneous, solid, and partially cystic. And you can see that it's actually sometimes difficult to evaluate. We can also do MRI imaging with abdominal MRI. You can do it with contrast and without contrast. And you can evaluate, in this particular patient, metastatic liver lesions within the this MRI pretty well. And this is actually the same patient that progressed and developed metastases in the liver. But we want to also start imaging beyond standard anatomical imaging with molecular imaging. And with standard anatomical imaging, we can see a lot of the basics of the anatomy. You can see actually delineate the borders of the tumor and where they're located. But it's really hard to say what is the characteristics of the tumor. So we're very good at defining the anatomy and the location and the extent of the disease and location of disease, but not so much in terms of, is this a neuroendocrine tumor if you just look at the liver, or is this something else? What's really nice is that you can actually use targeted imaging to describe the receptors on the surface of tumors, and you can characterize these on just imaging without having to do a biopsy. This is an example of a gallium Deuterate PET, which I'll describe this little alphabet soup in the next few slides. But what it allows you to do is to visualize somatostatin analog binding to a somatostatin receptor and being able to see it light up on the scan. I'm so glad Dr. Kunz mentioned the CLIA scan. That used to be the standard way of trying to see somatostatin receptor expression on tumors. And as you can see, these are not very good images and they're very hard to see. It's very difficult to tell where the tumor is. And this is actually the same patient I showed you earlier with pancreatic tail tumor. And you can barely see where this lesion is. And this is a planar imaging. And if we did SPECT, we could localize it to the left upper quadrant, but it would be very difficult to localize it to the pancreas very well. Also, if there were smaller lesions, we wouldn't be able to see it. And here's an example of Tria scan being lined up right next to Deuterate scan, gallium Deuterate PET, in the same patient. And you can see how many lesions are being missed on that Tria scan that can be clearly seen on the PET CT. But going to the DOTA part, a lot of folks ask me, DOTA, what is this DOTA? And the alphabet soup of gallium dotatate, gallium dotatalk, lutetium dotatate usually confuses folks, but there's actually a very nice logic to it. So let's go over that, because then you will never question what these are. So first, let's talk about labeling in chemistry. When you're thinking about PET radionuclides such as gallium and copper, which are used for imaging in PET, you cannot just give them to the patient. They're actually toxic. So you need to chelate them in the cage, and this is a DOTA cage. So you would chelate the gallium-68 in this DOTA cage. And what's really nice about this cage, it has a 4 different arms. And to these arms, you can actually attach your targeting molecule. So in this case, it's octreotide analog TATE. So you attach this peptide to the DOTA, and you have your radionuclide chelated inside of the DOTA. So there's a very logical name to this. This is how you attach it through the arm: gallium, DOTA, TATE. Very simple, right? So now that you understand this kind of logic, it becomes very easy to understand how we name these scans. And with the labeling, you can actually really be able to see this. So this is a gallium dotatate PET CT in a patient with multiple metastases, somatostatin receptor positive liver metastases. And you can actually see that there's also a periaortic metastasis in the lymph node that's outside of the liver. And here you have kidneys and bladder. So it really helps you evaluate the patients. In terms of the appropriate use criteria, I'm so glad Dr. Kunz had a full slide on this in terms of evaluating. Not all patients need to be getting gallium dotatate PETs, and we're still truly evaluating exactly where and when we should be doing these scans, but there's several indications that are appropriate, and some of the most indicative are the initial staging after histologic diagnosis of neuroendocrine tumor and localization of primary tumor in patients, because this scan is so sensitive for lesions, so you'll be able to see it. And then the other very common, very important point is selection of patients for some metastatin receptor targeted therapy, which we'll talk about it later. Now, what's really nice about this therapy, and this is where it's really revolutionary in medicine, is that you can use this method to image your tumor. So you have your radionuclide, you have your cage, and you have your targeting peptide. But then after you image the tumor, all you have to do is to pop this one out and pop lutetium 177 in. So you keep the molecule the same, you keep the targeting the same, but the radionuclide now is actually emitting beta particles that can act as a therapeutic for neuroendocrine tumors. So this would be called, very logically, I know you're thinking about this, lutetium, DOTA, dotatate. And there you go. Very simple. So we imaged with gallium dotatate and we treated with lutetium dotatate. And the only thing that changed was the radionuclide inside. So you know this drug, whatever we imaged, that's exactly where the treatment went. Now, we don't just have to do lutetium. We can also use other radionuclides such as alpha emitters. And here at Yale, we're now are approved to start doing these. And it's a very exciting new development to start doing these therapies in patients. So how do these alpha and beta emitters work? Well, for lutetium dotatate, and this is an image from AAA website where basically describes the mechanism of Lutathera, and you administer the drug intravenously. The drug gets taken up into the neuroendocrine tumor sites. The drug binds to the receptors on the tumor sites and gets internalized inside of the cell through endocytosis. And the radionuclide emits its particles, beta particles, or if you use an actinium type therapy, for Lutathera, it's really the beta particles because it's lutetium-177, and that can cause DNA damage. And once you have DNA damage, you can that can lead to tumor cell death. And that's the main mechanism. So to just kind of overview this again, in terms of image-guided therapy, you can select patients for whether they are eligible for this kind of therapy with your imaging agent, gallium dotatate, and you can see if the patient expresses the somatostatin receptors in the body. And in this particular patient, there are multiple metastatic lesions that can take up the targeting molecule. Then you bring the patient in and you provide intravenous therapy that is basically the same as the imaging agent, except it has the radionuclide that causes DNA damage. And what's really interesting is that lutetium can also emit rays that you can see on gamma camera, and you can basically see exactly where lutetium dotatate went. Now, it's not as crisp and beautiful as PET-CT, but you can actually see where this therapy went. And you can actually start doing dosimetry on these images. So this kind of technology allows selection of right patient and providing the right drug for the patient. And in neuroendocrine tumors, that has really changed how we treat patients. So the indications for lutetium dotatate, so these are the GI neuroendocrine tumors, and they have to be well differentiated G1 and G2 tumors. We need to confirm somatostatin receptor expression, and that can be done with gallium dotatate PET-CT. We're still allowed to use Arctria scan, and sometimes we will use it if insurance will deny the PET-CT, but you really want to be doing this with the PET-CT. We also evaluate bone marrow function, renal function, and liver function tests. And this is the point where nuclear medicine physicians are starting to become partners with oncologists and surgeons in treatment of these patients, because we no longer just read the images, we actually evaluate whether the patient is eligible for the study, and we evaluate follow-up, and we do dosimetry. And this is a patient-facing role for nuclear medicine physicians and radiologists. Now, even though the NETTER-1 has established the parameters for treatment of patients with Lutathera, but we're still figuring out the exact guidelines for which patients will benefit most. And there's a lot of active research going on in this field, and it's very exciting to be part of this field as we're expanding beyond the NETTER-1 trial indications. But you're probably thinking, well, what about FDG? FDG is used in pretty much every other oncological indication. How about neuroendocrine tumors? Well, a lot of the well-differentiated G1 neuroendocrine tumors are actually not hypermetabolic, so there's really no role for FDG in the well-differentiated ones, and there is a spectrum that the G1 neuroendocrine tumors will express a lot of the somatostatin receptor and will not have as much hypermetabolic activity, but the higher grade tumors, the neuroendocrine carcinomas and G3 tumors, they will have hypermetabolic activity. And there's still a lot of gray area in between them as well, because sometimes the lower grade tumors will also have hypermetabolic activity. But in nuclear medicine, we have this idea that there's a de-differentiation that happens. So this is a patient with a well-differentiated neuroendocrine tumor with multiple somatostatin receptor avid lesions. And this is a patient that had de-differentiated neuroendocrine tumor, which the tumor is now hypermetabolic. And this tumor may actually be photopenic on Deuterate PET as well, or it can actually express some somatostatin receptors, but not as many. So the exact point where we would treat these patients, particularly the ones that have FDG uptake, is still not fully evaluated, but hypermetabolic activity within these tumors is seen as a poor prognostic marker. So in terms of PRT treatment, the details for this treatment is we do right now a standard dose of 200 millicuries every 8 weeks, and we do 8 cycles. During the therapy, we do an amino acid infusion for renal protection, and we provide antiemetics for nausea. And patients usually will continue somatostatin analog therapy at this during PRT treatment. Now, a lot of you are thinking, well, how do we treat a patient, every single patient with the same dose? And you're thinking right. The whole field of Theranostics right now in treatment, PRT treatment, is moving towards personalized dosimetry. And that is becoming a big talking point with Society of Nuclear Medicine and Molecular Imaging, and major initiatives in dosimetry are being taken up. And the reason is Theranostics agents are becoming more and more available for different cancers. And in prostate cancer, we'll have a new theranostic agent that's very likely to be FDA approved next month. And with the targeted therapy, you want to think about it in a couple different ways, and just in terms of global way. With Theranostics, you can image the targets, such as location of the tumors, and that way you can provide targeted therapy in terms of location of the tumor, because you can see where the drug is, and then you can just exchange the radionuclide and target that therapy. You can also think of targeted therapy in another way, where you target a particular step in a mechanism of therapy, and that is targeting a specific pathway step. So for FDA-approved radiopharmaceuticals, there's really been an explosion in the recent years. So we really kind of started with the C11 choline for prostate cancer, and gallium dotatate was approved for neuroendocrine tumors in 2016, and then was followed by gallium dotatate. And the difference between TATE and TOC is in the peptide portion of the targeting agent, and they work pretty much the same in terms of ability to detect somatostatin receptors. We also now have a copper 64 labeled dotatate, and the therapy for lutetium dotatate has also been FDA approved for quite a while now. And it was basically approved based on the NETTER-1 trial, which showed improved progression-free survival in these patients. And I really appreciate Dr. Kunz going over this. So for future directions, we have to evaluate PRT efficacy in higher grade neuroendocrine neoplasms. We're also working on personalized dosimetry, so providing the right dose to the patient and hopefully see better outcomes in patients. And we need to evaluate indications for retreatment of patients. So after they completed the 4 cycles of therapy, what are the indications for repeat treatment, another cycle of therapy, and also of the alpha therapeutics. And another thing that we're working on here at Yale is personalized tumor-directed analysis with basically doing volumetric assessment of the different metastases and generating growth curves for each individual lesion in volumetric form, and following these growth curves and figuring out which lesions are growing and needs targeted therapy through different ways, and which ones are not. So in conclusion, cross-sectional imaging with CT and MRI can diagnose and follow neuroendocrine neoplasms, and they're really excellent ways to do imaging for these patients. But molecular imaging of somatostatin receptor expression allows for better molecular characterization of neuroendocrine neoplasms. Gallium dotatate PET is very sensitive for detection of metastatic lesions and allows to evaluate whether a patient is eligible for PRT. Lutetium dotatate therapy is established and allows to treat somatostatin receptor tumors expressing somatostatin receptor expressing neuroendocrine neoplasms, and it allows us to visualize the location of the therapy. And many advances for personalized therapy are being evaluated right now, so stay tuned to this field because it's really changing how we're managing neuroendocrine tumors. I really want to thank you for your time and pass the baton to Dr. Sajid Khan.
You're on mute, Dr. Khan.
Okay. Okay. I think I'm unmuted now. Is that right, Dr. Kunz? Okay.
Yes.
Okay. All right. Thank you, Dr. Aboian. That was just an outstanding talk. I learned a lot from that talk, and I'm sure a lot of people in the audience learned a lot. And Dr. Kunz's talk was also outstanding. So I'm going to spend the next 20 minutes talking to you from a slightly different perspective, and one that'll include the surgical management of neuroendocrine tumors. And since just the surgical management of neuroendocrine tumors is a large topic in and of itself, over the next 20 minutes, I'll focus specifically on pancreas and small bowel neuroendocrine tumors. And I'd love to answer any questions towards the end if there's time. I have no disclosures. So this is a slide from a paper that Dr. Kunz had cited in her talk, looking at it from the M group, where they looked at a SEER-based study of the incidence of neuroendocrine tumors over the course of time. And what's striking about this talk, and this is kind of the punchline, one of the points that Dr. Kunz made is neuroendocrine tumors are not necessarily rare anymore because the incidence of these is rising. And this includes the focus of this talk, which will include pancreas neuroendocrine tumors. And as you can see, there's been a very steady and then more recently a steeper rise in the incidence of pancreas neuroendocrine tumors. And in green over here, small bowel neuroendocrine tumors too, and that'll be the focus of this talk. I'm sure many people in the audience know that many of our patients are getting scans, cross-sectional imaging, and there are often incidental findings. And oftentimes these are how neuroendocrine tumors are discovered, as are other kinds of tumors as well. And I'm sure that's driving the higher incidence that we're seeing over time. So the interesting thing about neuroendocrine tumors is that the survival for neuroendocrine tumors is generally speaking favorable and the focus again will be on pancreas neuroendocrine tumors and small bowel neuroendocrine tumors. And the survival is dependent on grade. we're not going to talk too much about grade 3, grade 4 neuroendocrine tumors, and much of what we see are grade 1 and grade 2 neuroendocrine tumors. And then the survival is usually favorable, and that leads to the perspective of how these neuroendocrine tumors should be managed. And I'm going to give you my perspective as a surgical oncologist, and I think we all have our own perspectives on things. And as a surgical oncologist, longer progression-free survivals, the longer survivals impact what kind of surgical management we offer to our patients. So for the talk, we'll break it up into the remainder of the talk. We'll break it up into 3 different sessions. One will be the pancreas neuroendocrine tumors, which I'll talk about first. I'll follow that with the small bowel neuroendocrine tumors. And lastly, we'll talk about metastatic neuroendocrine tumors as well. These are common surgical scenarios that maybe some of your patients have experienced, and hopefully this will provide some guidance. So in regards to the pancreas neuroendocrine tumors, so I think in order to understand if someone needs an operation, one needs to just understand the basics of the neuroendocrine tumors. And these are some of the points that are important to a surgical oncologist when we see patients with pancreas neuroendocrine tumors. I'm very interested in tumor biology, and I can tell Dr. Aboian is also from her very elaborate talk. And pancreas neuroendocrine tumors arise from the endocrine cells of the pancreas, which are important to understand. And they account for 3% of pancreas tumors altogether. So still pancreatic ductal adenocarcinomas and other kinds of tumors comprise the majority, but 3% of pancreas neuroendocrine tumors are comprised of by PNETs. The median age of diagnosis is 60 years, and the survival is longer than pancreas adenocarcinoma. So that's a very important point to understand, as all of us in the audience, I'm sure, can understand. And there are obviously people, some celebrities over the years that we have observed that have been diagnosed with these kinds of tumors, both adenocarcinoma and pancreas neuroendocrine tumors. The node status is very important. So patients with node negative PNETs tend to have.
Sorry to interrupt you. Your slide is not projecting. It maybe, yep, there you go. Perfect. Thanks.
Okay. Sorry. So the survival is very important based on the nodal status. So patients with node negative PNETs have a very favorable survival at 136 months. The addition of the metastasis to lymph nodes decreases that survival to 77 months. And when patients present with distant metastases, the survival is 24 months. And that's important to understand because 60% of patients do present with distant metastases, and I think that plays into the decision-making process for how to treat the patient optimally. And as Dr. Kunz had mentioned during her talk, the majority of the cases are sporadic and some are familial. Pancreas neuroendocrine tumors are non-functioning tumors and functioning tumors. And by this, what I mean is that non-functioning tumors do not produce clinical symptoms, even though the tumors can still produce hormones, but they don't produce enough hormones to cause clinical symptoms. The non-functioning tumors now in the updated literature reveal account for about 75% of these tumors. I think some of this has to do with these smaller neuroendocrine tumors, which I'll talk a little bit about, that are diagnosed more and more frequently, and that number has increased over time. And then functioning tumors. So functioning tumors are tumors that have hormone hypersecretion that does lead to clinical manifestation. The 6 types are listed here, which are insulinomas most commonly that we see, glucagonomas, gastronomas, VIPomas, somatostatinomas, and others as well. Functioning tumors tend to have better survival than non-functioning tumors. And part of this probably is patients present with symptomatology earlier than non-functioning tumors, and that might lead to a better survival ultimately because it was diagnosed earlier on in the process. So when a surgical oncologist, if you come to Yale Surgical, see one of the Yale Surgical Oncologists, there are certain things that we think are important to guide our principles of surgical management of patients if we're assessing a patient for that. And our goals for surgery are The first is to maximize local control. So I think that's a very important point for not just pancreas neuroendocrine tumors, but in general for other types of neuroendocrine tumors as well. Another goal is to increase one's quality of life. Okay, so sometimes even non-functioning tumors can have an adverse effect on the individual's quality of life. So surgery can increase one's quality of life. Progression-free survival is an important point as well too, given this, the behavior of these tumors. A lot of times we focus on progression-free survival and not as much as overall survival. So progression-free survival is very important for this kind of tumor. Generally speaking, we aim for R0 resection margins, and that's something we strive for many kinds of surgical oncology operations, and that just simply means microscopically and grossly negative. We'll talk a little bit more about there's some difference. That's not always the case, but that's for some of the metastatic tumors, but we are usually striving for an R0 resection. And the final goal is we try to alleviate clinical symptoms, and this is very important for those with functioning neuroendocrine tumors. And if the source of the hormone hypersecretion is removed, it can substantially alleviate one's clinical symptoms and completely address it altogether. And we also, with our surgeries, a lot of these pancreas cases can be major operations, and but we do try to limit our short-term morbidity and the long-term morbidity as well too. And if you see one of the surgical oncologists at Yale, our role is taking this into consideration. So, so I'm going to give you some specific surgical scenarios here that might be of some use. One scenario includes a patient that presents with a localized non-metastatic pancreas neuroendocrine tumor, and generally speaking, we resect the resection is feasible. The median survival in the literature is 7.1 years, but the important thing to understand is that about half the patients do recur at almost 3 years. So recurrence-free survival is important to consider here as well. So many patients do recur. Another common scenario are these small pancreas neuroendocrine tumors. So these are pancreas neuroendocrine tumors that when we say that they're small, we're thinking 1.5 to 2 centimeters, and it depends on which studies you're looking at. There's a good study out of the University of Chicago. There's another good study out of Massachusetts General. And then that's where this number of less than 2 centimeters or 1.5 to 2 centimeters comes up. Because given the behavior of pancreas neuroendocrine tumors in general, sometimes surgery is not necessary for these patients. But I would recommend careful observation. Each patient is an individual, and every patient should be evaluated individually, but oftentimes patients with small neuroendocrine tumors can be observed. And I just want to make a quick comment about that. And that being said, if there's a young patient that's diagnosed with say, for example, a 1.8 centimeter neuroendocrine tumor that's in her late 20s or so, one can make a reasonable argument that with a longer lifetime expectancy, maybe that might not be the person we decide to observe with a small neuroendocrine tumor. And we do survey these patients, and if there are changes to their cross-sectional imaging, which is an important point for neuroendocrine tumors, we will consider them for resection. Another scenario that sometimes comes up is a locally advanced non-metastatic unresectable patient. In that kind of a scenario, sometimes we consider palliative surgery with some of the options listed here, and that's sometimes a scenario. And then limited liver metastases. We're going to talk at the last third of this talk a little bit more about metastatic disease, and in some patients with limited liver metastases, we'll use a synchronous approach where the primary tumor is addressed and the liver tumor is addressed, or we consider surgery in a staged fashion. So for all of these sections, I just figured I'd share some patient examples for you to try to put it into some perspective. And the first patient I'd like to present is an 80-year-old male who presented with hypoglycemic episodes. And he had what's called the Whipple's triad, which we've heard about. And for pancreas neuroendocrine tumors, what we teach our residents is, if you're once considering a functional pancreas neuroendocrine tumor, the workup starts with the biochemical workup. And this patient did have a biochemical workup, which indeed was consistent with insulinoma. After the biochemical workup, then we proceeded with the localization studies to identify where this tumor is located. And in this patient here, this is the frontal images, and it shows, I don't think my arrow is projecting here, but there's a hyper enhancing mass in the head of the pancreas, which is seen. And that is sometimes the look of how a neuroendocrine tumor shows up on cross-sectional imaging. And we performed a pancreatic duodenectomy with an extended lymphadenectomy on this patient. The specimen is seen on the right. And interestingly, immediately the patient's hypoglycemic episodes were completely resolved and provided this gentleman with many, many years of symptom-free life. Next, I'd like to transition to small bowel neuroendocrine tumors. And these are tumors that are submucosal neoplasms, which primarily arise from the jejunum and the ileum. And they do have neuroendocrine differentiation, just like some of these other tumors that we're talking about today. They have an ability to secrete functional hormones and amines. They are the most common tumor of the small bowel with malignant potential, which is interesting because this is shifted because when I was an intern almost 20 years ago now, we used to not look at small bowel neuroendocrine tumors as the most common small bowel tumors. We would think more of adenocarcinoma and then more often even benign tumors. But interestingly, now neuroendocrine small bowel tumors are the most common small bowel tumor with malignant potential. Nearly a third of these tumors arise relatively close to the ileocecal valve, and the reason that's important is our operative decision making takes that into consideration. Many patients present with multifocal disease. That's also very important when I talk about the surgical approaches. And about 35% of patients present with distant metastases. So surgical resection is a preferred frontline treatment for these patients. And the reasons for that is number one, it can improve survival. Number two, it can reduce the risk for developing metastatic disease. Number three, it can alleviate symptoms. And finally, number four, it can prevent or delay the onset of symptom development. And that's important as we talk a little bit more here. So, so I thought it would be useful to go over some scenarios that some of your patients may present with into the hospital. And one scenario is an asymptomatic patient, a patient that presents with asymptomatic disease with a primary tumor without distant metastases. So even though these patients present with asymptomatic disease, in retrospect, many of them will have some symptomatology and they won't know about it until after they've had their surgery. But that symptomatology may have prompted their imaging in the first place. In the cross-sectional imaging, Dr. Aboian can speak to this better than I can, but oftentimes it shows something such as a mesenteric or small bowel mass, which is hyper-enhancing, spiculated or calcified. And interestingly, in the operating room, the spiculation is something we really appreciate because these tumors in the OR or the mesenteric mass in the OR tend to be fixated posteriorly as opposed to something that's freely movable, which is the case with some of the benign small bowel tumors and even small bowel GISTs. Another scenario is an asymptomatic primary tumor with distant metastasis. I'm going to talk a little bit about that in the last scenario because I think that's going to be an important thing to go over. And symptomatically, sometimes these neuroendocrine tumors present with the bowel obstruction, abdominal pain, bleeding, and the so-called carcinoid syndrome as well. So an approach that is important is expectations for our patients. So if a patient knows what to expect in a non-emergent setting prior to undergoing a surgical oncologic resection, it goes a long way for their satisfaction down the road. And that's something that our group at Yale uses. So we talk to our patients ahead of surgery. And one thing that we talk to our patients about is sometimes because of the multifocality of these tumors, larger areas of small bowel need to be resected and it can lead to increased frequency of their bowel movements. We also consider for resectability, a lot of it comes down to the mesenteric artery and the vein, superior mesenteric artery and vein. That's something we strongly consider for resectability for these kinds of tumors. The surgery usually entails an enterectomy or small bowel resection with a lymphadenectomy. Sometimes it involves resection of a mesenteric mass, which is how a patient may present. And in the operating room, it's very important to palpate for synchronous tumors. So open operations are preferred. And I just want to spend just a minute talking about that as well too. So we do a lot of laparoscopic and minimally invasive surgery at Yale. A lot of our operations are done in that manner. And the way I look at laparoscopy and minimally invasive surgery is that it should be a tool to provide a good oncologic operation. It should not be the other way around, meaning someone should not get minimally invasive surgery just for the sake of getting minimally invasive surgery. But so for the way we approach these, we usually will do them laparoscopically to rule out metastases, and sometimes we could make a very small incision and eviscerate the tumor and palpate the entire small bowel to make sure that their synchronous tumors are not missed, which sometimes is the case with pure laparoscopic operations for these small bowel NETs. We evaluate for distant metastases and sometimes consider a cholecystectomy, and a lot of that ends up being a conversation with the surgical oncologist and the medical oncologist about if this patient may be a candidate for Lanreatide in the future, which can predispose to the development of gallstones. So a few scenarios. So a patient presents with an incidental finding on cross-sectional imaging. Our suggestions are that the patient should be evaluated by a surgical oncologist for resection. The patient presents with an isolated mesenteric mass or a small bowel mass. And the reasons we consider surgery are, again, it can be diagnostic. Sometimes these tumors are not always neuroendocrine tumors, but they usually are when we look at it with our radiologist, but sometimes they're not. So it's something to consider. An operation is potentially curative. And this is very important. It can avoid future symptoms of bowel obstruction, bleeding, or ischemia, which sometimes happens if these small bowel neuroendocrine primary tumors are left alone. So that's an important point to mention. And we do see that some time and again with the patient that had a neuroendocrine tumor which was being observed, and the patient can present with some symptoms down the road, and of course it can reduce the risk for metastases. Another scenario is an asymptomatic primary with distant metastasis, and again this can be we would suggest to be evaluated by a surgical oncologist, and the reasons for surgery again are to avoid future complications and metastasis, and this kind of an approach can still provide a progression-free survival advantage. And then if sometimes patients present symptomatically, and a patient that's presenting symptomatically should probably just get to the operating room and be seen by a general surgeon in the local hospital, because sometimes these patients don't have room to be transferred, and an acute bowel obstruction should just usually be managed locally. And the reasons for this, of course, the obvious, it alleviates their symptoms. It can be diagnostic and be potentially curative. And a patient example here is an asymptomatic patient with an asymptomatic small bowel NET. This is a 59-year-old male who presented with a 4.2 centimeter hyperenhancing mesenteric mass on CT for abdominal pain, which resolved by the time we evaluated him. And then this picture shows a CAT scan with a hyperenhancing 4.2 centimeter mass, which we ended up taking to the OR and resecting, which is shown all the way on the right. And we did an en-bloc small bowel resection with the mesenteric mass, and the surgical pathology revealed multifocal tumors, node-positive disease without metastasis, and it was a grade 1 tumor. And finally, I'll end this session by talking about metastatic neuroendocrine tumors. So again, some perspective on things from a surgeon's perspective. So the reason we find this important is because a third of patients present with distant metastases, and the liver happens to be the most common site of metastasis. Metastasis is important because it negatively affects survival, as we know, and that's the case with all cancers. And there's an increased risk of death compared to an individual that has localized disease. Clinical presentation can include hormonal symptoms, and that's more often the case for small bowel NETs. This could be diarrhea, wheezing, and flushing, and sometimes the patient could have right-sided valvular disease, which can lead to heart failure. And pancreas neuroendocrine tumors are important. They're often non-functional in cases of metastasis. The arguments supporting surgery for metastatic NETs are the first, and the important thing is to control the tumor burden. And by resecting one's metastatic neuroendocrine tumors, the progression-free survival improves with patients as a whole. And the literature can show 5-year survival of up to 74%. That's overall survival. But the important thing to understand is there's a high risk of recurrence despite that kind of an approach. So even though I'm talking about 5-year overall survival of 74%, the recurrence rate is over 80%. But there is benefit to doing this because it can provide effective symptom control, particularly for functioning tumors. It could prevent or delay the sequelae of carcinoid syndromes. It can improve one's performance status and pain, and this is the case more for non-functioning tumors. And the number has shifted as to the percent of tumor that we'd like to cite or reduce in an individual. And there was a time where we used to think more along the lines of 90%, but more recent literature has suggested that that number might be closer to 70% reduction of the tumor burden. And it's important if one can have this type of cytoreduction, and we usually try to remove the primary tumor and the regional disease in this 70% number that I mentioned. But even if one does not have their primary tumor that's identified, one can still consider a cytoreductive surgery if greater than 70% of the disease burden that's clinically present can be addressed. And extrahepatic disease is not a contraindication to surgical cytoreduction. The tools that we use in surgical oncology for cytoreduction, and I'm focusing a little bit more on the liver because I'm very biased towards the liver, and I like operating the liver. And then this ends up being one of the most common sites, or the most common site of metastatic disease for NETs. We often will try to do what's called parenchymal sparing resections because, as I mentioned before, many of these patients recur, and they can have a longer survival, and they can recur in the liver. So we try to do parenchymal sparing resections when possible, understanding that, well, if there's another recurrence down the road, it can allow the patient for a second liver operation or liver-directed therapy down the road. But sometimes we do need to perform major hepatectomies given the distribution of metastasis. Sometimes we consider a microwave ablation, where we put a probe into the center of the tumor, or sometimes our interventional radiology colleagues who are very adept at doing that can do that as well too. And if they can do it in a less invasive fashion, that's always the best thing for the patient. And surgical cytoreduction should be attempted when it's anatomically feasible and can be performed with a low morbidity. So I'll end with a patient example, and this is a 62-year-old male who, when I had seen him, was 5 years after the status post-distal pancreatectomy for non-functioning pancreas neuroendocrine tumor. One of his smile medical oncologists was surveying him and identified enlarging hepatic lesions on surveillance cross-sectional imaging. And this doesn't show everything, but this is a patient that had 3 tumors when we had seen him. One in the left lateral liver, one in the left medial liver, and then one in the right liver. And then we went ahead and we actually needed to do a major liver section for the left side and a parenchymal sparing resection on the right side to clear all of the disease. And we did a cholecystectomy in this case as well too. And the pathology revealed 4 neuroendocrine tumors, which were identified in the liver, which were well differentiated. So the surgical management of pancreas and small bowel neuroendocrine tumors, the incidence is rising. Resection of primary neuroendocrine tumors has clinical benefit, and we've shown that, and I've shown that for pancreas neuroendocrine tumors, both non-functioning and functioning, and for small bowel NETs. And finally, surgical cytoreduction for metastatic NETs has clinical benefit if greater than 70% of the tumor burden is resected. Okay, thank you for your time.
Thank you to Drs. Aboian and Khan. Those were both great presentations. So I think what we'll try to do is tackle some of the questions that have come through the chat. And I also have some questions for the two of you, and we can have a conversation. So one of the first questions that came through is, I think this was in reference, and Dr. Aboian, maybe I'll direct this to you, is can the Lutetium treatment, the PRT, if it started early, can we achieve cure from this? And particularly if the cancer load is low. That's, I think, aspirational, but I will allow you to maybe comment some on that. What are the goals of treatment, and in what setting do we typically use it?
Yeah, this is a really great question. Now, the indications for which PRT is being used for right now is for well-differentiated tumors. And when we do the therapy, majority of the tumors actually do not decrease in size, but it does slow their growth. So there's significant improvement in progression-free survival. So no, this is not a cure, but it does improve symptoms and improve survival in patients. So that's for the lutetium. We still have a lot of other therapies in the pipeline that we're still evaluating, but the goal is not cure. The goal is extension of life and improvement of symptoms.
Thank you. There was another question that I think perhaps Dr. Khan can answer. So, and I think you addressed this a little bit in the course of your presentation, Saj. So is it possible that we maybe can't find the primary, but we do see metastatic disease? You touched on that a little bit in the course of your surgical indications, but maybe you can address that some.
Yes, yeah. So that's not an uncommon scenario, Dr. Kunz, and that's a very good question. And it is always worth it to look for the primary tumor and do a thorough, exhaustive look for the primary tumor. However, if the primary tumor cannot be found, there is benefit towards if a patient has a resectable metastatic disease, which could be cytoreduced to over 70%, and the morbidity is not very high, I would still recommend consideration for surgical cytoreduction because of the improvement in the progression-free survival.
Yeah, and I'll just comment this, entity of unknown primaries is certainly something that we come across, although I will say I think that's less in the era of gallium-68 PET scans. I think we are often identifying the primary a little bit more easily with better imaging. But we do still see that. I have a couple of questions. Actually, I think there was one more in the Q&A from the audience. So, and this is something maybe I'll tackle first, but would welcome comments from my partners here. So some cancers, even lung adenocarcinomas, have endocrine secretion. How can we treat that? I didn't personally spend a lot of time talking about how we treat hormone control, but I think certainly for many patients with neuroendocrine related hormone secretion, the mainstay is really using somatostatin analogs first. They were approved on the basis of controlling hormones, specifically carcinoid syndrome, which is diarrhea and flushing. They are also indicated in some other forms of hormone secretion, including gastrinomas and others. But we also try to cytoreduce or kind of reduce the bulk of the tumor either through surgery, as Dr. Khan indicated, or other systemic treatments that have the ability to shrink the tumor. So cytotoxic chemotherapy can do that. Dr. Khan, I think, spoke about some of the ablative procedures. We didn't talk tonight a lot about liver-directed treatments, but I think that when patients have secretion of hormones, it's tricky because we need to think about both managing the hormones and managing the tumor itself. So Dr. Khan, do you have any other comments on that?
Yeah, no, I think those are why, if an individual has a patient, if a provider has a patient with, a neuroendocrine tumor general, but in this specific scenario, it's good to have them evaluated in a multidisciplinary fashion, because surgery, I'm not saying everyone needs surgery, and sometimes systemic options are much more effective at controlling these symptoms than surgical options, and I think that's why an active discussion by a multidisciplinary tumor board is very beneficial for the patient. But if one is able to control a high burden of disease, like I threw the number 70% out there, that's for surgical literature, but I don't know if this is true or not, but perhaps that is true for non-surgical approaches as well too. And I think if we're able to address the source of where the hormones are being secreted from, we could probably really provide some good clinical relief to our patients.
Right, right. No, I agree. Good. Dr. Aboian, I have a question that comes up almost in many of my patient interactions and also when I'm teaching trainees. This actually just came up yesterday. How do we interpret SUV on gallium-68 PET? Should we pay attention to it? Is it different than how we think about FDG PET?
Oh, yeah, that's a great question. We can give a whole lecture on tracer uptake. I would think I do recommend to, so it's a general unit of tracer uptake that's generalized to patient's body weight. But the big issue.
Oh, we lost Dr. Aboian there for a moment. So hopefully she will be back. I can text her. Technical issues.
Deuterate and Deuterate, they will be a little different.
Dr. Aboian, we lost you for just a minute. Maybe you can repeat.
Sorry.
That's okay.
Sorry,
The last portion of that.
Oh, sorry, I was having internet connectivity issues. So, so in terms of the SUVs, it's a way to measure tracer uptake normalized to patient's body weight, and it is a semi-quantitative PET measure. Now, there's a whole field of quantitative PET that requires very complex mathematical modeling, and here at Yale, under the guidance of Dr. Rich Carson, their leaders, the Yale PET Center, are in quantitative PET imaging, and we're still trying to figure out how to apply it to clinical practice because it's not used in clinical practice. But SUV is kind of a poor man's approach to try to quantitate, so it's a semi-quantitative measure. But I would really focus on looking at SUVs within a specific tracer. So if you're going to compare SUV values, only compare them between gallium dotatate scan. Don't compare them between gallium dotatate and DOTA-TOC or gallium dotatate and FTG. If you have a patient that's being imaged with FTG PET, then you can compare the SUV values. But if your patient changed significantly, so suppose they lost a lot of weight in between the scans, then you have to be really careful. Usually in nuclear medicine, when we do the reports, we do mention the numbers because everybody wants some quantitation, but we do try to use language as well because it is a semi-quantitative analysis.
Thank you. Yeah, that's helpful. Dr. Khan, I have a question that comes up a lot in tumor board. I think I'd love to hear from you of, are there situations or notable situations where you're like, gosh, I really wish I saw this patient earlier? Like when should medical oncologists or surgeons in the community be thinking about surgery? When should it be on their radar? I'd say specifically for metastatic disease.
Okay. The first, maybe I can also answer one about non-metastatic disease. I think if one identifies a hypervascular mesenteric mass, I would consider that. I wouldn't just sit on it. I would consider sending it to one of the surgical oncologists, or at least one of the general surgeons, to evaluate for it, because every so often we do see a patient that has had this followed on cross-sectional imaging and then presents with some sort of a problem with the primary small bowel related issue, whether it's ischemia, infarct, or bowel obstruction, and then it becomes more of an emergent problem, and it's something that probably could be less of a bigger operation. For metastatic disease as well too. So actually, the last patient I presented was being followed for a while because the tumors were visible, and I had given a talk on liver metastasis about around that time. And then the individual who was caring for that patient didn't realize that surgical option's an option for that patient. So I think if a patient is known to have a neuroendocrine tumor and perhaps present with liver metastases, I think it's worth it for that patient to be seen by a GI medical oncologist or a surgical oncologist, because I do think that we can provide a good progression-free survival benefit for most patients in that kind of a scenario with a good multidisciplinary approach.
Great, thank you. Dr. Aboian, maybe I'll ask you one more, and sort of, I'd say a really exciting direction and something you and I are partnering on is really thinking about a Theranostics program. Can you speak to how you think the field is changing and how we are likely to see the development of Theranostics programs sort of in multiple locations, but maybe the value of that, what that means, and sort of how nuclear medicine docs are going to be providing direct patient care?
Oh, thank you. Yes, this is a very exciting field, and I just came back from Society of Nuclear Medicine and Molecular Imaging Therapeutics conference, where we met for several days and talked about how different sites across US are starting the Theranostics centers and their layout plans and how they're going to be treating the patients. And this is really changing radiology and nuclear medicine. We are now going back to seeing your patients. We're now becoming parts of teams with oncologists and surgeons and really practicing together, and with radiation oncology as well. And we're really practicing together as a team in terms of taking care of patients. There's sites where a patient is being seen by their GI oncologist and followed up by a visit with a nuclear medicine doc to discuss PRT and the specifics of radiation-based therapy, radionuclide therapy. And that really helps patients in terms of understanding what they're going to be undergoing and their side effects and the risks. The nuclear medicine physicians are following up on the patients and are involved in the care. So another thing that's really helpful is that we're starting to combine chemotherapy with radionuclide therapy in trials and trying to see how we can improve the efficacy of these therapies. And the only way to do it is to work together. So it's a really exciting team-based approach that's happening across the country. And it's really going to change radiology and how we care for our patients.
That's very exciting. I think lots of opportunities for asking for both providing really excellent patient care. And I think, one thing we can speak to is really the importance of multidisciplinary care for the care of these patients. I think the intent was to have 3 different disciplines represented on this panel tonight. And I think we all certainly work together in caring for our patients with NETs. So I think what we can do is, I don't know if Dr. Aboian or Dr. Khan, you had any other burning questions for each other or anything that has come up? If not, I really want to thank the 2 of you, certainly for your time and excellent presentations. I want to thank our audience for their time and listening tonight. This has been recorded, so we will make this available to the community. And stay tuned for our future GI CME series in April and May. We will promote those and hope that some of you will listen again. So thank you and have a wonderful evening.